Dr. Gimbel showing an intumescent cataract, the shallow anterior chamber. We never know, seeing these white lenses. Sometimes you can get an idea whether it's brunescent underneath that or all soft material. My technique for white lenses is to use viscoelastic cohesive if I'm suspicioning intumescence and a lot of posterior pressure. But I always put the vision blue underneath the viscoelastic, whether it's cohesive or dispersive, and just paint the capsule. This is more effective in my experience because the vision blue is against the capsule for a longer period of time for more effective staining. And also, the vision blue does not stain any other tissue. Once we aspirate the excess, we add more viscoelastic to clear the area. And I start with a small capsular rhexis just to be safe in case it is intumescent. And we'll often then enlarge this after lens removal. Or we can sometimes enlarge it as we're forming it by just taking a second spiral around the first. It's just safe to not plan on a large one to start with until you're sure there isn't going to be liquid cortex obscuring your view. So the cortex is not too liquid on this case. And as we remove some of that white cortical material, we can see this is a pretty dense lens. I don't usually I don't usually hydrodissect these cases because the cortex is so liquid. You can see here it just rotated spontaneously without hydrodissection. My first description of divide and conquer was a crater divide and conquer, which this case is demonstrating, removing a lot of the central dense material of the lens, not just in a groove, but sculpting, rotating to create the crater. Sometimes in very dense lenses you have to, as it's being shown here, emulsify against the dense material instead of sculpting. This phaco energy is dispersed right against the lens material. I have found it's not really damaging to the endothelium. So prolonged phaco with proper technique is not damaging to the endothelium. I've done cases with very long phaco times and the cornea the next day is still clear. So if the energy, like I said, is down deep in the lens, absorbed by the lens material itself, it's not damaging to the endothelium. So this lens is fracturing quite easily and demonstrating the technique of making smaller than quadrants to emulsify. And if this were more brunescent, I would take even a smaller segment. Try to get the complete separation in the fracture, leaving segments there to just have more stable situation for rotation and subsequent fracturing of all of the nucleus. Removing the first one does allow for a little easier separation, so I always remove the first one, but then subsequent ones can be left in place. One can also add a dispersive viscoelastic at this point. To protect the capsule, because we don't have our cortical epinuclear material here protecting it as usual. Nice graphic with this lens material and with the cortex and nucleus being aspirated. Shows the red reflex very well. You can see it doesn't take much vacuum to emulsify this. We're occluding it. I think our maximum here is 175. There goes our cohesive viscoelastic now. You can see all of that fracturing, and it was leaving cohesive viscoelastic in the anterior chamber until just now. And that also shows that the energy and the circulation is pretty limited when you're down in the capsule, in the crater of the fractured lens. So if you're worried about lens endothelium, adding a dispersive viscoelastic before lens removal here would be good, or if you're convinced that it's not a liquid cortex situation, one could use a dispersive to start with. So we have to be careful here to keep, without viscoelastic now, to keep segments away from the cornea. And we can use our second instrument. This is a Hefliger chopper made by Moria, designed by Dr. Hefliger. Protecting the posterior capsule with the chopper underneath, the cleaver he calls it, underneath the phaco tip while we're in ultrasound mode. Just being careful not to get the phaco tip against posterior capsule. Kind of rigid material, so it doesn't want to occlude. Sort of flat material, so it's hard to get an occlusion for emulsification. And looks like that port occluded our tip. Which we don't like to see. That's the advantage of using higher vacuum, but then there's the risk of more surge with higher vacuum. So we're going to take the phaco tip out. Probably adding a dispersive viscoelastic here. Which in retrospect might have been better to put in even earlier.